Thank you very much. So, we're going to be talking today on body dysmorphic disorder. And what I want to try and do today is be able to focus on the phenology and making a diagnosis of BDD, just have a think about some of the developmental factors that we've been picking up, have a good cognitive behavioural understanding of BDD, look at also the evidence for SSRIs and antipsychotic drugs, and then evidence for and principles of CBT. So that's what I'm going to try and cover. How common is it, first of all? Well, it's actually surprisingly common. Just about every psychiatric disorder is 1 or 2% in the community, and it's just the same for BDD, but we don't tend to see it, of course, in general psychiatry. Looking at a few private psychiatry inpatient units around the world, it was about 5% when it was undetected, but of course it's mainly occurring in cosmetic surgery, dermatology services. The nature of the procedure there may be important, so that there are certain procedures that seem to attract more. But generally in psychiatry, it's almost never picked up without a screening question we can talk about. So when you finally come along to specialist psychiatric clinics as such, we know that the onset tends to occur during adolescence, but it takes about 10 years before finally getting adequate treatment. They tend to be then equal sex ratio, single, separated, and there's high degrees of comorbidity that they've collected over the years in terms of additional depression, social phobia often precedes it, or OCD as well. But there's high levels of suicide attempts. In these samples, about 25% will have attempted suicide, and we know from prospective studies from colleagues in the States of Catherine Phillips, about 0.3% per annum go on to commit suicide each year. The other thing that's interesting about it is it attracts a lot of stigma and trivialization. So, for example, there was a very nice little editorial in the British Medical Journal here, where you can put there's a bulletin board that occurs after it, and people can write their comments. This is a fantastic example of stigma in action by a GP who wrote, "I wonder the value of devoting an editorial to BDD. You know, whilst it may appear to be a debilitating condition, the 1 in 236 one-legged mind victim, Cambodian mind would disagree. You know, what are they really saying is that real disfigurement is worthy of our attention, and often what seems to happen is it gets confused with body dissatisfaction, because, of course, we're all dissatisfied with our body in some way. And the reason why I've always been interested in it is that there's a failure to identify and treat it. There's a low level of awareness general still about it. It's more likely to present to dermatologists, cosmetic surgeons, and there's a secretiveness about it and stigma, because individuals with BDD don't tend to reveal their actual problems unless they're asked, and more likely to present to you with depression, social anxiety, OCD. And it's still little research, treated often inappropriately, but we do have nice guidelines now. So what I'd like to do first of all is just show you a very short film, because trying to convey the nature of BDD to members of the public is quite problematic. So this film was designed for the public, but hopefully in the 2 minutes you'll pick up the phonology behind BDD and see what you think. So you can have the lights down and put the popcorn on. Get a popcorn. Here we go. So I hope you like that. It's actually my daughter. This is the sort of thing we get up to at weekends, the sort of family videos, that sort of thing. But hopefully you can get across the key issues there. So hopefully you picked up on the preoccupation, the perceived defects in the mirror, the way that excessive self-consciousness, and so on. So let's just try and unpack that a little bit. So the key thing, first of all, is a preoccupation. The definition is more than an hour a day, just thinking about your perceived defects. That the key thing is that it's not noticeable, appears only slight to others. Now, it is possible that you might get up very close and you can raise your aesthetic standards and you can just about see what they're getting at. Yes? But there's an extreme self-consciousness and these ideas or delusions of self-reference. Where do they get preoccupied by? Well, it's all over the body, but it's predominantly on the face. So it's flaws, thinning hair, too much hair, acne, too greasy, I've got open pores, I've got wrinkles, I've got scars, I've got paleness, I've got too red, I'm not symmetrical, I'm not disproportionate, I'm just too ugly, I'm too masculine, I'm too feminine, anything really. But most commonly on the face, and the top 6 is around the nose, skin, hair, facial, the eyes, teeth, lips, chin, or ugly in general. But, any part of the body may be the focus, and we've looked at people with men who are preoccupied by their genitalia, and women seeking labiaplasty, so it can occur anywhere around the body. And of course, the reason why it's part of the obsessive compulsive and related disorders now is that of these repetitive behaviours. And I'd really like you always to think about the function, the motivation behind them, because they generally are very similar to OCD, that they try to verify, to see whether in fact it's as bad as you think it is, to try and camouflage, or to try to repair it. In other words, a bit like washing in OCD. So there's lots of mirror gazing, checking by touching, inspecting, measuring, comparing yourself with old photos or others, lots of ruminating, trying to convince others about how bad it is, lots of grooming, combing, smoothing, straightening, plucking, cutting hair, skin cleaning, facial peeling, scrubs, bleaching, lots of facial exercises to follow, and of course the mother of them all, the cosmetic procedures and the dermatology. And it causes lots of interference in life. There's a lot of avoidance of public and social situations. They're frequently single, discord in relationships, because it's not very attractive if you're constantly preoccupied by how ugly you are. And they're often unemployed, they've got occupational, academic disadvantages, and as children were refusing school, they're often in debt from cosmetic procedures, they may be housebound, severely avoiding, and frequent hospitalisation. So the first hopeful message is try and just check it out, because if you don't ask, you won't get. And especially in those people who present to you with depression, substance abuse, or social anxiety, because the stigma of BDD is much worse. They fear being labelled as vain or narcissistic or being laughed at. So just a very simple question like, some people are very bothered by the way they look. Is that an issue for you? And if they would say yes, you'd like to ask a little bit more about what concerns do you have about your appearance, how noticeable do you think it is. What you're looking for is there a discrepancy between the perceived defect and how you see them. You might go on to say, on a typical day, how many hours a day is it at the forefront of your mind, your appearance? Do you have to check your appearance a lot? Is it very distressing, shameful for you? Does it interfere with your ability to study or work, and interfere in dating, relationships, and social life? And you can do that very quickly, within 5 minutes, to make a diagnosis. And there may be a number of observations that you can notice as well, that they might be wearing a hat, baseball cap, sunglasses, baggy clothes, scarves, inappropriately like in the film. These are all camouflaging. They may have visible body piercings or tattoos to try and distract attention away from their perceived defect. They might be heavily made up. They might have their head shaven in order to feel that they don't have to keep getting their hair just right. They may have long hair to hide their face like a form of camouflage. They might be sitting in a particular way to hide their worst side, or find it difficult to make eye contact. They might have skin picking, scars. So there's all sorts of things that you might pick up in terms of just thinking about it. And as you heard this morning, ICD-10 is DSM-4 has changed, of course, but ICD-10 is very unhelpful for BDD because the symptoms of BDD are described under hypochondriacal disorder, schizotypal disorder, delusional disorder, or other persistent delusional disorder. So we will have ICD-11, which Naomi and myself have both been contributing to on this obsessive compulsive and related disorders. So from what Naomi showed me this morning, it does differ slightly from DSM-5, because we've got these two new ones of hypochondriasis, which we've nicked from somatoform disorders, and we've also rescued olfactory reference disorder from psychosis, because, again, it's very similar to OCD, lots of repetitive behaviours of checking to see how much you smell and things like that. But that's the new family that you have to become accustomed to. So, how do we try to understand the nature of BDD? So, if you're thinking about these things psychologically, we have to have a good understanding of phenomenology. We have to try and understand the cognitive processes and behaviours, and really key to understand their motivation, the function of these behaviours and processes. And then we go on to do experimental studies to determine whether they're maintaining factors in the symptoms, and then we try and develop interventions and test them out. And just thinking about the phenomenology, first of all, the thing that we first of all lighted on was the imagery, because both BDD patients and controls will experience imagery of how they think they look, but the BDD patients will be able to rate them as more vivid, more recurrent, and more distorted, and much more likely to be viewed from an observer perspective, that is, looking back at yourself. And what we say is that they tend to define their self as like an aesthetic object, and often associated with early memories, particularly like being teased and changes that occurred during adolescence and sometimes abuse and so on. And one of the difficulties is trying to work out exactly how to capture that imagery. So one of the ways we do that is to get people to do a self-portrait. And so you can come up and see my etchings, lots of different ones, in terms of, really, I think, conveys to you the horror in terms of how people feel that they look. Because, of course, this person doesn't look anything like this, but that's how they feel they look. And they can describe these things to you as she does in words, but it doesn't really convey to you, I think, the horror of how she feels. This is somebody else who looked in the mirror after she'd been raped at the age of 16, and she doesn't have PTSD, but she still feels that way as how she looked like in the mirror 10 years later. And you can also use these things as outcome measures. So this is me doing a psychorhinoplasty. As you can see that on the left, you can see how this man felt that he had a very large nose. And after therapy and I think medication here, clearly his body image has changed. And this is a great outcome measure, I think. It's also great for when you talk to cosmetic surgeons, because all they do is show you their before and after pictures of their handiwork. And one of the things that surgeons go on about, of course, is doing cosmetic surgery to the face and doing complete surgery. Of course, we've done that ages ago, where this person actually felt on the left that she was from outer space and that she didn't have a nose and a mouth, but after therapy, even schematically, she felt, she could get it back again. So psychiatry and psychology can do magic in a much better work than cosmetic surgeons. And again, it's not necessarily a visual image. Here you can see this person has got a very, not a picture in his mind, but he's got a physical sensation of heaviness. It feels like this to him, a bit like what we used to call the Mekon in Dan Dare. And again, somebody, doesn't look anything like this before treatment, and after treatment she's very different. A young girl who feels that she has acne, but again, she doesn't it's very hardly noticeable, very mild acne. I think she had acne in the past. But again, after treatment, you can see, and she's obviously a very good artist, looking a little goth-like, but clearly very different from how she was successfully treated. And just lastly, you can see here again on the left, a woman who felt that she had a very enlarged jaw. She felt she looked like a monkey, but after treatment, it gets back again. You can see actually there's a side effect here of therapy that we managed to reduce her breast size. I'm not quite sure how that happened, but it's a side effect. I know Alan's very young, that we do report side effects of treatment, psychological treatments. And one other diagnostic thing, you can see on here that this, often people with borderline personality disorder have a very distorted body image. Many of them, would fulfill diagnostic criteria for BDD, but it's you have to retreat the borderline stuff first. And you can see it's a very almost diagnostic, I think, of borderline personality in terms of her lack of identity and the way she feels about her appearance. It's complete lacks all structure. So self-portraits, we think, can be quite powerful ways of capturing that phenomenology. And the other thing is that what we talk about is the self as an aesthetic object, the way that people see themselves. So here is somebody who has got a very distorted picture in his mind of how big his nose is, but the way he generally tends to see himself is as an aesthetic object. It really defines his self and his identity. And you can see there the way people are looking at him, and it's spotlighted. He is just a walking nose. That's how he views himself. And again, I love to think in pictures here. You see, this is a picture I picked up at Chelsea Flower Show, and I can't imagine having that in my garden. But it is a very, again, picture in my mind of somebody who gets all the information in the world from all the shit in their head, as it were, in the sense that they're very self-focused. Yeah? And so what we say is that a lot of these individuals have got memories of being teased, about being different or abused in some way, which may not have been emotionally processed. So we're using almost like a sort of PTSD type model, and that's been conditioned to their body image. And we certainly think that helps a lot in engagement in therapy, because we can start talking about how that this is a problem to do with some of the past experiences rather than a problem with their appearance. So what we say is that over the years that such individuals have got very self-focused attention on that constructed body image from an observer perspective, which has become fused with reality. And there is some evidence that people have got more accurate and sensitive perception of their actual face. In fact, they've lost their rose-tinted glasses, that you and I tend to see ourselves as more attractive than we actually are. Yeah? So there's this loss of rose-tinted glasses. And when they're looking in the mirrors, or just generally think, they tend to focus in on their defects compared to their overall appearance and self as a person, that they have these idealized values about the importance of appearance and defining their self. And they're very much motivated to avoid rejection, humiliation, and some of the memories that perhaps from past experiences. They're constantly comparing with others and ruminating. Why was I born this way? If only I hadn't seen that surgeon, and so on. And then it leads to lots of avoidance and safety-seeking behaviours and all that comparing and camouflaging. And all these things function to try to check to see whether in fact you're really as bad as you are, think you are, trying to camouflage, or get it better again in some way. And so you follow all these different cosmetic surgeries. So it becomes more understandable, I think. So we do have nice guidelines. It's very much, it got bundled in with the OCD, which is just as well, because it was unlikely to have other nice guidelines on BDD by itself for many years. And really it's the same treatment guidelines, as it were, for OCD. And it just says, well, if you've got mild impairment, you should be getting brief CBT. If you've got moderate impairment, you should be offered a choice. And severe functional impairment, which is by the time they could probably get to see you, should be offered a combined treatment. If that doesn't work, you should be going onwards and upwards in terms of perhaps a different SSRI or clomipramine, and referring onwards to multidisciplinary teams of expertise in OCD and BDD. And when it says more intensive CBD, it just means more frequent or more experienced therapists, higher doses of sertraline or citalopram with ECG monitoring, as you heard this morning. And then, then there are intensive treatments and inpatient services for severe chronic services, and you can get either local or national funding for that sort of severe treatment refractory BDD in those designated units. So what do we do in CBT? Well, first of all, the biggest single thing is engagement. We really want to try and get a good understanding of the development of the problem, the sorts of associations they'd made with their body image when they were younger, and try and help them to update those memories. And then we focus on the maintaining factors, all the avoidance, the safety seeking, all the checking behaviours, the ruminating, the comparing, and all that self-focused attention. So you really have to unpick them all one bit by bit. And where we're talking about Dodo's treatments this morning, I mean, actually anxiety disorders are different. So for anxiety disorders, OCD and BD, we have now got good evidence that CBT is better than something else. And the thing we usually use something else is anxiety management to try and control for the amount of time that the person sees a therapist, homework, and having a good rationale that they both believe is a good credibility and expectation for treatment. And it's also done blind. So even though we've got investigator bias here, the ratings were done blind. We had before this 3 RCTs of CBT versus waitlist, and we needed to demonstrate that it was better than an equally credible treatment. So we actually had a very simple randomization of CBT or anxiety management, stratified for delusional disorder and depression, and our primary outcome measure was a blind observer. Both groups were baseline 12 weeks and then followed up for a year plus. And when you do a trial, then if you want to get the best effect size, of course, you really try and recruit very easy patients. But here you just have to take anybody who comes through the door. And here you can see the duration of the problem was 11 years. Half of them were regarded as having delusional disorder, and 43% depression and social phobia and so on. 45% were already on sort of optimal sort of SSRI. And 37% had already had CBT in the past, 61% had already had a previous SSRI, 83% didn't want our treatment, they wanted a cosmetic procedure, and a third had had at least one cosmetic procedure in the past. And if you're doing such a study, you really need to make sure that both treatments have equal credibility and expectation. And here they were both saying that equally they were both rubbish and they didn't really want the treatment, thank you very much. But we were able to demonstrate that there was significant differences between the groups. It's not fantastic, but it was superior to anxiety management. And in terms of the categorical things, we're helping about 50% of people, and that's maintained at long-term follow-up. Full remission, we're not doing very well. It's only about a quarter of people who get cured. And partial remission is about 50%. So it's not fantastic, but this is a difficult group to help. But we are only doing it for 12 sessions. Limitations, small studies, no other control with medication, for example. We do think we need to optimize the length of therapy. We think we need up to 20 to 24 sessions, maintenance follow-up. We need to optimize the treatment of depression and develop new treatment modules. So we're still quite early on. We have also contributed to the same type of study just against CBT against a waitlist in children. So it doesn't present as commonly as OCD in children and adolescents, but it does present. And we're able to demonstrate, similar to adults, a good effect size of here 1.13 compared to a waitlist. What about SSRIs? Well, there's only been one good SSRI treatment. There's one on clomipramine as well, a crossover. But here what they did was to look at fluoxetine placebo for 12 weeks, and very similar to CBT, about 50% responders and about a 33% reduction on the main outcome measure. The key thing here to remember is that delusional patients do just as well as non-delusional. We don't know the effect of discontinuation, but it's very likely to be similar to OCD with high rates of relapse when they're discontinued. And that's, you can see the difference there. So modest, but important. And it's probably similar to OCD in the sense of being dose dependent. So something like fluoxetine, you want to try and at least get up to 60 milligrams. What about antipsychotic augmentation? Well, whereas in OCD there is some small benefit in some patients with adding particularly aripiprazole or risperidone, there's not that evidence in BDD. Now, people have always thought, well, delusional, you must have an antipsychotic. But if you looked at this study, and this is, remember, pimozide, those are old enough here, remember, was the drug that was used for dysmorphophobia, had absolutely no effect in these patients in terms of non-responders to fluoxetine for 12 weeks. And there in the States, they go up to 80 milligrams a day. And so here they were using pimozide, no difference, and so in the NICE guidelines, antipsychotics are not recommended at present. It may be that you may still use them in a low dose, particularly for those people who are very agitated or as a last throw, as it were, but at present there's no great evidence and there's no difference to placebo. What do patients with BDD want? They want cosmetic surgery, and it may be that certainly when we look at all the ones that they have had in the past, there are some procedures like mammoplasty, labiaplasty and pinoplasty that we found are probably safe, and it's probably because these things are obvious in the sense that people know exactly perhaps how things are going to change. But things like dermatology and rhinoplasty was the most common in our surveys and the worst satisfaction. After surgery, they often transferred the preoccupation to a different area, but that was more likely to occur where you have multiple preoccupations. If you've just got one preoccupation in one area of the body, which is a safe area to go for, as it were, then it may be okay. Successive operations, and I think my worst one was had about 9 rhinoplasties, led to decreasing satisfaction after each time they had one. A few might develop BDD after surgery. And the other thing, just to remind myself, is of, this is a picture I took in Myanmar, Burma. It's of a pilgrim offering the Buddha her breast. As you can see, it's cut off. It was refused by the Buddha because he's a vegetarian, but the point is that you can have DIY cosmetic surgery, and we've collected a number of people who did, for example, pinch and stapling their skin for rhytidectomy. Those are facelifts. He narrowly missed his facial nerve, filing down the teeth to alter their jawline, supergluing their ears for pinoplasty, sandpapering their skin for dermabrasion, which isn't a lot different from what dermatologists do, exsanguinating themselves to look paler, cutting themselves to release fat for liposuction, and even putting an iron on their face to remove their wrinkles. So they were all highly dissatisfied by their outcome, but you can see sometimes how severe these individuals are in terms of how desperate they are to change their appearance. So when patients say to you, I'm going to have surgery, because they don't ask your advice, all we can best say is that having BDD makes satisfaction surgery unpredictable. It seems that some people may get some benefit, but we really don't know who. At best, you may be satisfied when it's got an ambiguous type of problem, but for many procedures, it's unlikely to alter the symptoms of BDD or the focus of the preoccupation changes. It's more risky if it's type time changes, where, like a rhinoplasty, at worst it may make the preoccupation handicap worse. You offer to discuss it with a surgeon, but usually such individuals don't want you to know who the surgeon is, and everyone's compartmentalized. If you're determined to have surgery, then we usually try to delay treatment. What we'd love to do as a bucket list is it's got good prospective studies on people having cosmetic surgery, but it's very difficult to do, and no one's going to fund it. There is one very small cosmetic survey study, prospective one in France, where they followed up people who had minimal defect, and they managed to identify those people who had BDD and 8 who didn't have BDD who had surgery. And what was interesting was that the satisfaction of surgery was quite high, but 6 of the 7 BDD surgery patients still had BDD and high levels of handicap than those without BDD. But 3 who didn't have BDD pre-surgery then went on to develop BDD after surgery. And this would be great to replicate in a much larger study with a specific procedure like rhinoplasty, which, in my view, is the biggest single problem area in cosmetic procedures. So that's going to finish there. If you want to read more about it, we have a treatment manual and a self-help book as well. But that's time.
So thank you very much, David. Before we just start with questions, can I just remind everyone to fill in the appraisal forms, please? It's very important to us to get feedback. So we're open for questions. Perhaps I can kick off. That's a fascinating area. What about skin bleaching? I mean, that occurs with some racial and ethnic groups. It seems to be really quite common in Africa and so on.
Yeah. Well, as you say, it might be a cultural thing, wanting to fit in and wanting to make yourself more, make yourself more westernized.
Yeah.
We don't tend to see it so much in people with BDD. It does come up as a procedure that people may sometimes use, but not so much.
Okay. Dr. Johar, can we give him the microphone?
Hi there. I was just going to ask you what you think is happening with delusions in BDD, because I liked what you said about olfactory reference syndrome. You take the evidence for therapy being more helpful than medicine. You change your diagnostic classification based on that. But, you know, one of the tenets of our dopamine hypothesis has always been delusions responding to D2 antagonism. What do you think's going on?
Yeah. Well, if you look at the obsessive-compulsive related disorders, there are some conditions like OCD where you do occasionally get delusions, but there are a low proportion of them. BDD, it's about 50-50, and then you move on to things, and health anxiety, sometimes you get delusions, but things like olfactory reference disorder, it is higher again. It's probably about 70-80%. So there's a whole range of strength of belief, shall we say, but they don't seem to, as you say, really respond to antipsychotic drugs. And I think that's correct. I mean, just clinically, antipsychotic drugs do well with major positive symptoms, don't they? Things like agitation and thought disorder, hallucinations. But single circumscribed delusions don't tend to necessarily respond so well.
There was an old literature about monosymptomatic hypochondriacal psychosis. And
Munro.
Sorry?
Munro, Alistair Munro.
Alice Munro, who was in Halifax. And I must say, I've only had about 2 or 3 patients, and when I've used Pimozide, it's worked remarkably well. So I don't know if that's a separate, small issue.
It'd be lovely to do a big study on it.
Yeah. Lady with a question?
Yeah, I just wondered, I had a young girl who's got schizophrenia in the clinic the other day, and she's got a beautifully symmetrical nose. I mean, sort of the sort of thing that you'd kind of comment on in the magazine as being pretty perfect. And she was determined to have cosmetic surgery on her nose. And she's going to pay privately to do it. And she asked me to write a supporting letter because her GP was rather dubious about it. She also had some problems about acne and wanted that sorted out as well. I refused and said, I think your nose is, there's nothing wrong with it, and I can't honestly justify supporting this cosmetic surgery, which I think she will go and have. I think she can probably get it done privately anyway, but I probably lost her engagement really, because but I just wondered, so from your perspective, look, if that was just straightforward BDD, you would say I should say, okay, fine, go and have it potentially.
Rhinoplasty, we think, is a particularly risky area, even for people without BDD. So we would try to do our best to try and persuade that person not to have the cosmetic surgery or to delay it in some way. But sometimes, you just can't win sometimes. And when people are so determined and they manage to get money from family or to steal it or this, that, and the other, they will have it done. And you may then be able to follow them up, and they may develop regrets and so on. But there's only so much you can do, because they won't let you know who the surgeon is. There are questions, I think, sometimes whether they have capacity to make such decisions. I've never yet been asked to make a capacity decision-making on such individuals, but it's very tricky.
It's very tricky. I would say she probably doesn't have capacity, because
I agree.
But
can she weigh up?
But I don't know that the surgeon will ever ask me, and in my experience, when I've talked to them, they haven't been very happy about it.
But isn't that the point, that there surely is a duty of care from... the surgeon is not just a technician performing something irregardless of the well-being of the patient. Surely there's a duty of care of the surgeon to, first of all, be able to assess capacity, which you don't have to be a psychiatrist to do. And secondly, to at least, it doesn't seem to be particularly difficult to screen for this, David.
Absolutely. But I think you talk to the surgeons. There are some very good surgeons out there who will be very cautious and refer you suitable patients and everything else. But there are a lot of cowboys out there. And the problem being is that they genuinely believe that they can enhance the person's appearance. And that, everybody here can have their appearance enhanced. So that's the problem.
Well, on that startling note, let's thank Professor Veale.